for the invitation. And I will try to share the screen. And can you see the presentation?
Yes, we can.
Okay, thank you. The presentation is about a recent paper published in JACC Cardiovascular Intervention regarding CTO and bifurcation lesions. This paper has been written by members from the European Bifurcation Club and members from the EuroCTO Club. My conflict of interest. And the first slide is about the incidence of bifurcation lesions in the context of CTO. We analyze in the paper different series and collect 9,000 patients, as you can see in the table, and the incidence of bifurcation in the context of CTO is high. The distribution regarding the proximal cap, the CTO body, or the distal cap is almost 1/3 in each location. In this context, a specific complication can appear. We know that CTO is a complex lesion with a relatively high incidence of complication, but in combination with the bifurcation, the procedure is much more complex. And in this context, the differential complication is the side-blank occlusion. Side-blank occlusion occurs during CTO in a high proportion of cases, between 8 and 25% of the cases. To preserve the side branch, we need to know different strategies, and when the bifurcation is located in the proximal cap, it's easy to protect the side branch. In contrast with the bifurcation located within the body of the occlusion or in the distal cap. In all the case, we recommend to wire the side branch as soon as possible, and in case of a bifurcation located in the body or in the distal cap, try to avoid the technique of dissection and re-entry. How to avoid side-blank occlusion is in the paper, we describe different strategies regarding the location of the bifurcation with respect to the CTO. In the CTO, in the bifurcation located at proximal cap, this is the more easy situation, and the recommendation is first wiring the side branch, the use of IBUS to facilitate the optimal penetration of the proximal cap, and use the provisional strategy in most of the case. Bifurcation at CTO segment or situation of this bifurcation situated in the distal cap are more difficult to preserve the side branch. Predictor of bifurcation, the location at the CTO segment is a predictor of bifurcation treatment failure. Double lumen catheter is useful in this situation. The need for two stents is relatively high, between 15 and 49% of the case, and the use of dissection and re-entry technique induce sometimes or most of the time the loss of the side branch. So this technique should be avoided in bifurcation located at the body. In the distal cap is similar. Bilateral approach is recommended. IBUS is useful. Antegrade or retrograde dissection and re-entry should be avoided. if possible, and provisional stenting generally recommended. How to manage the difficulties in the cyber access? We know that the technique developed for regular bifurcation are also applicable for the context of CTO plus bifurcation. This slide summarizes a simultaneous consensus paper published in the same year, and all these recommendations apply to the bifurcations in the context of a CTO. To summarize, prevention of the cyber occlusion, we recommend the use of the yelled wire. Sometimes it's difficult, and for facilitate this maneuver, microcatheter, dedicated microcatheter are useful. The angulator or dual lumen catheter, deflectable microcatheter, etc. And all these recommendations are useful to the bifurcation lesion located in the CTO. The role of dedicated microcatheter is really important and really useful. You can see in the table the available microcatheter in the market are similar, and in the lower part of the panel you can see a clear example of the need for this tool. This is an example of a right coronary artery that was recanalized by antegrade technique. The wire is in the PDA, but you have to recross, you have to put a second wire in the PDA. For this maneuver, the use of the double lumen catheter, as can you see in the central part of the slide, is relatively easy. And after introduce a second guide, you continue the treatment of the bifurcation lesion as a regular bifurcation. With a provisional stenting, obtain this excellent angiographic result. The IBUS is also useful to manage the difficult cyber access. This is an example. This is the classical example of an IBUS catheter located at the side branch. The operator tried to introduce to make the puncture of the proximal cap with a second wire. In this position, the wire is subintimal. In this position, the wire is in the center of the plaque. So this is the correct position that allows advance the wire and obtain the true lumen location. After the recanalization, you continue as a normal bifurcation, and in this case, again, provisional stenting with a final kissing balloon was enough to resolve the bifurcation. This is another example in which the IBUS is useful to assess to identify the subintimal tracking at the point of the bifurcation. You have two possibilities. The first possibility, this is the more favorable possibility. After recanalization of the CTO segment, the wire is located at the LAD. You perform an IBUS and see that in the center of the CTO, the position of the wire is subintimal, but at the end, the wire reach the true lumen. And the relationship with the diagonal branch is favorable. Is diagonal and LED are in the same lumen. So in this case, again, provisional stenting is the technique of choice. That after dilation, main vessel stent implantation, and kissing obtain Again, an excellent result. This is an example of an unfavorable situation. In this case, it's a right coronary artery that was recanalized by retrograde approach, and a dissection was produced during the recanalization process. The IBUS informed us that the PDA and PLA are in different lumens, separated by the subintimal tracking, and this case need the use of a double lumen catheter and a stiff wire to try recanalize the PDA. After this maneuver, the dissection is frequent, and the need for a two-stent technique also is the rule. In this case, the ETITAP resolved the situation with an excellent angiographic result. And the third role of the IBUS in bifurcation is in the case of ostial LAD occlusion. In this case, normally the recommended maneuver is to try to recanalize the occlusion antegradely or retrogradely, but if you need a cart, do the cart distal to the left main. In this case, we can't obtain a good position of the antegrade wire. We use a retrograde technique and try to reach the true lumen of the left main. But during the maneuver, an image of interluminal hematoma was produced with the almost occlusion of the left main. This is a complication that was quickly identified by IBUS. We extend the left main to the circumference and continue the recanalization of the LAD using the kissing wire technique. We obtain the true lumen, make a first kissing, implant a second stent at the LAD in a culotte technique, a second kissing, and this excellent angiographic and IBUS result. This is all the possibility of all the mechanism of side branch occlusion, of the side branch compromise during the treatment of a bifurcation in the context of the CTO. Plaque shift and carina shift have the common mechanism in regular bifurcation. This mechanism may occur in CTO plus bifurcation, but in the combination of both, some intimal shift and intramural hematoma are even more frequent. This is the more frequent mechanism of side branch compromise and specific of this technique. This is an example of a subintimal shift in a recanalization, antegrade recanalization of a right coronary artery. We have a retrograde technique, a retrograde wire from the PDA to the PLA. We have the wire, and after the introduction of the antegrade wire, you can see that the antegrade wire achieve the PDA in a subintimal position. So you have the intimal and unintimal flap separating the bifurcation. You have to work again with a double lumen catheter. You have a dissection everywhere, and you have to finish the procedure with two-stent technique. In case of carina shifting, is the normal rule, the rules for normal bifurcation, previously published in several consensus, are summarized in this slide. I don't want to insist because it's well known. Pod, kissing, use of the dedicated CTO, use the yellow wire technique and try to rescue with all the maneuver previously described, with a dedicated microcatheter, or even in case of difficulty, you can also use the yellow wire to dilate the side branch and try to dilate outside of the stent, then correct, and etc., etc. So, in conclusions,
Right.
sí. Conclusion, bifurcation as an additional strategic technical challenge to CTO recanalization, technique to preserve side branch integrity in bifurcation lesions developed by the European Bifurcation Club are applicable to the context of CTO PCI. Provisional stenting is recommended in most of the cases, and two stent strategies are reserved for cases with difficult access to the side branch or dissected segment at the side branch. Thank you for your attention.
Thank you very much, Dr. Pan. Bill, do you have any questions for him as he presents his paper?
No, I mean, I really thank you, and it's a pleasure to be on with you, Dr. Penn. It was obviously, these are very challenging cases. I think when the side branch is at the proximal cap, it's really not part of the CTO, and so it's often not an issue whatsoever, like you had said. I'm curious, when you have scenarios where you are in the true lumen distally in the main branch, and you have a flap across the side branch, and you've lost visualization, how do you approach that? I mean, retrograde is obviously one of the only real reliable ways to come back to the actual takeoff. But if you can't see it and you're not really seeing it great by IVUS, which is a lot of times the case if there's calcium, do you have other techniques that you do for that? And I guess that would be my first question, and then I have a follow-up to that. But how do you find that takeoff of the side branch when it's within the CTO segment, but you don't clearly know where the cap is? Do you have techniques to try to mitigate that other than retrograde?
Yeah. I think the use of IVUS is useful to inform you about the anatomy of the bifurcation, the position of the dissection, the relationship between both branches, and in case of unfavorable situation, as you mentioned, the use of double lumen catheter is the rule, and try to reach the second branch with the use of dedicated hydrophilic technique or whatever, in accordance with the experience of the operator, from the trying to orientate the over the wide port of the double lumen catheter in a favorable position, in order to facilitate the passing of the second wire to the side branch. I think is one of a useful maneuver in this difficult situation.
I understand that completely. My question is, I think if you can't see the cap by IVUS, which is not that uncommon, especially depending on how experienced people are looking for a cap by IVUS, which can be very hard to find sometimes, and you're not clear where to actually take your hydrophilic wire to start digging, you're kind of working blind. And I'm just wondering, like, do you have any ways that you've overcome that? Do you have particular wires? Some people feel like miracle wires kind of feel the cap or will catch on the cap but not perforate because they're not tapered. Obviously, retrograde is a great solution, but we don't always have a retrograde option to that side branch. And so I'm curious, in the States, and I know it's not looked at favorably at all, I think, in outside of the US, but star techniques are used a lot in these situations, and we've gotten pretty good at having a balloon in the main branch going out the branch that we've crossed. We sort of straddle that, and then take a jacketed wire like a Gladius and fold it upstream, and it sort of forces it out into the side branch. And so you can star into the side branch and then balloon that length and kind of reestablish at least flow to it, maybe not the ability to end up with a beautiful bifurcation stent at the end. But I struggle with that because I don't have a way of knowing where to actually dig. And usually, with a true bifurcation CTO, you have a real CTO segment between your main branch and the side branch. And so So it can often be difficult to know exactly where to go. Do you have other ways of doing it? Do you guys star at all, or is that just completely seen as not an acceptable option?
I agree with you that in these cases is a difficult situation, and all the tools, all the maneuver that have to be used, the retrograde and all the catheter, all the microcatheter, all the wire and patient. No?
We've had some nice cases too, where you do have flow into that side branch, but you have your carinal shift, or you have a dissection flap like you described, blocking access to the side branch. We've had a few of those, not a ton, but maybe 5 or 6 that we've been successful with reverse wiring from the recanalized branch. So you'll take your, I like to use a Xion Black, but we'll take that down over a dual lumen microcatheter with a hairpin bend on it and drop it down in the open distal lumen of the 2 side branches. And when you come back, there is a actual connection between the 2. It's just downstream. And so if you position the tip of the wire against the inner curvature of the bifurcation segment, you can sometimes sneak that wire into the side branch, and basically when the wire unfolds, it pushes that carina, pushes that flap out of the way, giving you access, which is really elegant, because it does keep it so that you have a confluence of your 2 wires in the same lumen, which allows you then to progress with bifurcation stenting or treatment in the usual fashion, almost always stenting in that scenario. Have you employed that at all? Have you tried doing that much? It might be something for people to think about if you find yourself in that situation. I think the other situation that we run into, and I'm going to show you a case that has a lot of the things that you described, which is really elegantly discussed in your paper. The other situation that we run into is if you did do ADR and you do have a flap across, but you are able to get a wire into the true lumen downstream of the side branch, but you can clearly see that there is a flap between your two lumens. You're in a true lumen distally on both halves, on both branches, but you clearly have a flap or separating the 2 at the carina. And how do you approach that? Do you use cutting balloons? Do you try to just macerate the tissue so that you can develop a confluent zone there that you can treat, or do you go back with a sharp tapered wire and try to puncture through that flap upstream a little bit to be able to use your other wire as a marker to understand where you're going? Have you had any good advice for us on how to do that?
Yeah, I think it's a difficult situation. There is not a definitive rule to approach this problem. I think that if the side branch has a retrograde collateral, you can use it. This is a possibility. But in general, bifurcation located in the body of the CTO is a factor of failure of the procedure in terms of recovery the side branch. My approach or the general consensus was use all the maneuver as previously mentioned, the double lumen catheter, trying to orientate the port and perforate the membrane of the dissection in order to reach the lumen of the side branch, but sometimes you fail. So it's not not always you obtain the success. In case of crossing with an additional dissection, the recommendation of use 2 stent, I think this is in this situation. Finish with 2 stent. In general, provisional is enough for most of the bifurcation lesions in the context of the CTO, but in this situation, the recommendation of 2 stent is the rule.
Let me ask you with that, if you go to a 2 stent strategy, which oftentimes when you have these scenarios, what I'm describing, where you do have a flap that you've had to overcome, and you are successful wiring both now, and you've ballooned both with kissing balloons to prepare it, and then you decide that you're going to need 2 stents.
Yeah.
Do you have a rule of thumb or a way that you approach of, one, what's your stent strategy, and 2, what do you treat first, knowing that you're going to have to rewire through the stent into the other branch? And I'm curious, I read your article, but I didn't know whether or not you talked about what 2 stent strategies are employed most frequently.
Yes, it's variable. It's quite variable. In general, although starting by the main vessel is the rule. Sometimes if you have a long dissection at side branch, it's difficult then to recross through the main vessel stent. So in this case, I like to start stenting the side branch first and do a T or a mini crash, and after the main vessel stent implantation, and finish always with a kissing balloon.
Great. I mean, that's one of the times when you do have that flap that you're still dealing with, like you described. You have a long dissection going into the side branch before you entered the true lumen. We don't use a lot of, or I don't use a lot of cutting balloons, but that's one time that I think that there is some value for doing cutting balloons and even kissing cutting balloons to try to fenestrate that flap a little bit more. And then I tend to treat the dissected side branch first, keeping my wire jailed in the main branch, and then come back through. And we end up doing a culotte on that a lot of times, because I think it's a fairly low stress way of doing it, because you're going to maintain access to the main branch in all likelihood, and you have your wire marking it. And then if you do have the unfortunate situation where that flap does extend across your main branch, since you have it marked, it becomes pretty easy most of the time to penetrate that with a tapered penetrating wire and get back into the true lumen, and then you can work your way through. But it's really nice presentation. Maybe I'll share my case with you and see what your thoughts are, and see if you have any things you would have done differently or advice. Yeah, I think you would have to stop sharing first. And I don't think Dimitri is going to be able to join us. I don't think he can get his computer working. So I think it's going to be you and me discussing things, Dr. Pan.
You can see your slides, sure.
Perfect. Good. So it's a pleasure. I appreciate Dr. Rabb inviting me to speak here. I'm at Emory with Dr. Rabb. I'm the director of interventional cardiology, trained here under Dr. Rabb many years ago, back in 2002 to 2006. And it's really been a great privilege coming back. I'm going to show you an interesting case. This is a 58-year-old gentleman that had a recently diagnosed reduced ejection fraction, mildly reduced at 45%. Had been having progressive dyspnea on minimal exertion with increasing severity over the past year or so coming into this case. Has a history, kind of the classic risk factors of hypertension, diabetes, and hypercholesterolemia. Left heart cath is performed. This was done at an outside hospital. I'll show you the films. But if you look, and you can tell it's not done at our hospital, because we don't pan ever, because we did 420 CTOs at our facility last year, and so we have pretty stringent ways that we do the angiograms. But I think it's very difficult to interpret these angiograms for CTO PCI if you're panning. But you can get the gist of what the issue is here. So this is a right coronary dominant vessel, obviously, but not a huge PDA. And if you look, it really sort of has mild septal collaterals connecting to the LAD, which is obviously occluded. And then there's a big RV marginal that comes around and hits the apical LAD. And it's important there too that this RV, there's another small branch, and I'll pause this for a second, but there's another small branch coming off that's actually going to give rise to some connections to the LAD as well. And so both possibility of septal connections, but these epicardial connections up towards the tip would not be usable safely, I think, in pretty much anybody's hands. This is the LAD, and it's interesting because it brings up two of the scenarios that you describe in your paper. This has both the side branch, actually has two side branches at the point of occlusion. But then as you're going to see when we do the dual injections here, so this is for people just to get oriented, because I've seen this case 1,000 times, but nobody else has seen it before. And so this is the left main. Obviously, we've got a fully preserved circumflex, and then a ramus branch coming out in the middle. The LAD is flush occluded at the ostium of the LAD. And so dual injections here, I think, will help kind of understand what the challenge is here. But if you look, you not only have the flush occlusion at the takeoff of the left main, creating a bifurcation scenario there, but if you look downstream, you have a large diagonal segment as well as the LAD segment. So both are completely occluded and do not join as a confluence. So it's a true double CTO with two branches, both in a bifurcation fashion. And so did this case with my partner, Dr. Rinfret, for a live case, and it's an interesting case. It's a challenging case, and I think I'm curious. What would your starting point? I suspect, and I don't want to put words into your mouth, but I would suspect that you would probably think about an antegrade IVUS guided cap puncture to start here, Dr. Pan, or would you think about retrograde from the beginning, knowing that you have a couple different really challenging scenarios that are coming your way, either way that you go?
Yeah, it's a very difficult procedure. You have a ostial LED occlusion and then a side branch starting at the body of the CTO. So my approach probably would be use the IVUS as circumflex in order to make a puncture of the proximal cap. And also, I would try a retrograde approach, not through the epicardial, but through the non-epicardial, through the septal connections, and I would start in this way and see what happens.
Yeah, and I think we sort of debated quite a bit. Obviously, we've got a wire in the circumflex, kind of following your guideline rules of protecting the side branch as quickly as possible from a side branch standpoint, but also from a patient safety standpoint during the case. And we looked at these septal connections, and they don't look totally unfavorable. They are tortuous. They clearly do connect to the mid LAD, and so if you could get into one of those, and for these kind of situations, we use a SUL 3 a lot of times to try to navigate that very tortuous proximal portion of the septal, and then find its way up north to the target vessel of the LAD. If that doesn't work, we pretty quickly switch to a Xion black. We did not feel that this epicardial was usable. We did surf these septals quite a bit, thinking that a retrograde strategy would be nice to start out with and at least define the anatomy. And I think a tip injection, if you were able to get retrograde, may define whether or not this is really truly another CTO, or whether there's a confluence of this LAD diagonal bifurcation. We were not able to get through the septals despite trying for quite a bit of time. But if you look here, I'm going to pause this so you can see. If you look here, if you forget about the septals and you stay in this branch all the way out here, this does connect upstream. And so we took a SUL 3 there, and we were able to navigate our way out to that segment. And this is just another example showing you what the LED diagonal is going to look like with dual injections. If you wait till the very end of the contrast, you'll see the complex anatomy that we're in for. And so after quite a bit of time, we were able to get into this smaller coming off an epicardial and let it sort of walk its way up. That's a SUL 3 walking its way up to the distal cap, which we use quite a bit, and I think it is a very, very nice wire for these situations. Also, probably the most atraumatic at only 0.3 gram tip. It's very unlikely that you're going to cause any real problems, although I've definitely perforated several epicardials with them, so it can definitely be done. So I wouldn't consider it a completely safe wire. But we're sitting very nicely at the cap here, retrograde. We took our microcatheter and we were able to track without a whole lot of difficulty all the way up to the distal cap. So we basically have at least gotten into the beginning of the case, and so we have an opportunity to do something. So this is our microcatheter sitting on the distal cap with a tip injection to try to understand, is there the hope that maybe there's a confluence? And you can see pretty clearly the contrast just basically rebounds right off the distal cap and heads down the LAD. So there's no upstream connection. So it's kind of the worst case scenario that you're sort of coming into, saying now we've got a true CTO segment with a true large diagonal coming off of it in a bifurcation fashion with probably 5 to 10 millimeters at a minimum of actual occluded segment between the LAD. And so this is a scenario that, as you described, is really unfavorable to do ADR, because if we do ADR or retrograde reverse cart in this occluded segment somewhere in there, the side branch is coming off, and so our access to that is going to be greatly inhibited. And so what we did is we did, looking at this again, you can see the flush occlusion of the LAD. We did take some time with IVUS. We were able to sort of understand where the cap was with IVUS, and then came back and with actually this is a Judo 3, we were able to puncture what we thought was the cap of the LAD. We did not go back in IVUS to look and see because we had our microcatheter in. We would need 8 French guides or else ping pong guides to be able to have real-time IVUS at the same time that we're doing a cap puncture. If we wanted to use a microcatheter, if you didn't want to use a microcatheter for your penetrating wire, you could do it obviously in 7 French, but for us, we did not have 8 French here. So we made the puncture where we thought we were going, but the nice thing is you can see that wire is really tracking our retrograde gear. So even if we're not going to do reverse cart, just having the wire in position retrograde really gives us a good understanding if we're heading in the right direction. And this kind of shows that nicely, as you can see our retrograde gear sitting in the target LAD, albeit for a short period because we came in the LAD probably around here. But our antegrade wire is definitely in the vessel architecture, and it's definitely dancing with the retrograde gear. And so this poses the next kind of question that you come into is, what's your next step here? Do you go ahead and commit to the fact at this point, in experienced hands, we're going to get the LAD almost for sure, because we're going to be able to do reverse cart here, which is going to work almost every time. But it's going to be at the expense of potentially creating a flap across that big diagonal that we would also like to capture at the same time. And I don't have a solution for this. So I don't know where that cap takes off. I know my antegrade wire here, unfortunately, is not true lumen, so I'm not going to see the cap by doing IVUS. So I don't have a good way of overcoming this. So to me, this is kind of becomes more luck than it becomes skill. And I'm not sure if anybody really has the answer. I'd be curious if you have any suggestions of what you would do to not go and press forward with capturing the LAD and knowing that you have a significant chance of never getting access to that diagonal again.
Sometimes we use an IVUS at the left main and try to make the puncture through the retrograde wire and stop if the wire is not interlumen. This is a possibility. The second one is the reverse cart. And
I think so. So we took your first strategy. So we came back with our retrograde wire and went back with a guy a third and spent quite a bit of time trying to wire true to true from where we were into the true lumen of the left main. We were unable to do that with quite a bit of effort, and I think with some real experience at doing that in the past. So I think probably a good effort on our behalf. The other option we thought too was that our antegrade wire maybe started sub and wasn't in the true lumen from the beginning. We thought maybe going back and IVUSing that to try to maybe repuncture the proximal cap in the true lumen would be a good strategy as well. We thought at this point that maybe we would take an antegrade knuckle and push it a little bit and see kind of whether it wanted to define itself and set up. We were thinking of setting up for reverse cart, thinking maybe we could come back and star into the diagonal, which is a technique that we use not infrequently in the States. And I think, again, it's not the most favored thing around the world, but we're part of the STAR registry trying to figure out, what are these patients, how do these patients behave long term when you come back and take a look at them at 8 or 12 weeks. What's your ability to rewire into the side branch through some of the fenestrative flaps that we invariably connect? But you can see this knuckle, this little antegrade knuckle, and that's on a Fielder XT, is headed towards the diagonal, right? So it's not mirroring the LED, it's clearly heading out to the diagonal. And so for better or worse, we thought this was good fortune. We thought that this is heading towards the side branch that we were concerned we may never get access to again. And so we took to true wiring here. So we tried to true wire the diagonal. And so we pulled our knuckle back, didn't extend the flap any further. And if you look here, we're able to take a guy a third, and this we were able to penetrate. And then that wire looks very favorable at that point. You can see it kind of release. It looks like it's in the true lumen of the diagonal. And so we were comfortable with that to track that down and trade that out for a soft wire. You can see with the injection now that this wire in the diagonal is definitely in. And so you can watch downstream when the contrast blends in with the wire. So we definitely have wired the diagonal at this point. And so we've wired the proximal LED. We've gotten into the body of the LED. We've got the first diagonal. And so at this point, what we thought was the most elegant way to do this, and you kind of alluded to this, that you would use IVUS to guide you with this. But one of the ways we like to do this is take a guide extension catheter into the LED at this point. And so we balloon the cap of the LED into the diagonal, and then track a guide extension catheter out to the carina. And this is kind of a rough drawing of what that looks like. And so we've got a true lumen wire in the diagonal. We've got a wire that's subintimal or extra plaque retrograde sitting here in the LED, and we balloon the guide extension out to the carina. And so if we put this right at the carina, if I can then hit this guide extension with my retrograde wire, I've at least got a very short flap at a worst case scenario, and more likely a confluent zone between my two wires. And so we pulled this Fielder XT, or I'm sorry, I think it was a Fielder XT retrograde. So we pulled that retrograde, and we were able to do just that. So we were able to wire with a Gaia third into the guide extension. The guide extension accomplishes a couple of things. It guarantees me that I'm not re-entering in the left main, because I'm re-entering in the guide extension. It's already sub-selective into the LED and wedged all the way up to the carina of the LED diagonal. And it puts me in a situation where...
Did you consider the use of a double lumen catheter through the diagonal wire and use the retrograde wire as a kissing wire technique?
I think we do that a lot. So we use a ton of dual lumen catheters for that very purpose. And I think it would have been a very reasonable alternative strategy, probably may have been successful as well. I think if this hadn't worked, what we were doing, if we couldn't wire into that, I think that would have been probably the next step to do. I think that the nice thing about what you just described there is if I take my dual lumen catheter and I start my antegrade wire right at the bifurcation point of that diagonal that's in the occluded segment, then if I get downstream, I have the freedom to do reverse cart in that zone that's between where I came through the septal and the LED, and I'm downstream from the diagonal takeoff. And so now I can go outside in the subintimal space and make my connection, and I'm not going to compromise the diagonal takeoff. And so I think it's a very reasonable alternative strategy. Both would work. I think this was kind of a neat way of doing it, just because it kind of takes some of the guesswork out of play. But certainly a dual lumen would have worked nicely. You can see that's what we did then. So we externalized. We use an R350 almost all the time to externalize, but we externalized that and then brought a dual lumen catheter down on the antegrade wire that's in the LED. And obviously our coming through is in the mid septal, but you can see we can just pop that wire out the side branch and then wire the LED downstream. And so now we have the LED and the diagonal both. And so the question is, do these both take off from a common area, or is there still a dissection flap between the two? And that just has to do with whether we were fortunate enough to puncture through any material right at the mouth of that guide extension, or whether we punctured through further downstream. And so we IVUS that, obviously, and you can see clearly on IVUS, fortunately for us, that there was a common zone where both wires were in the same lumen. And so even though we had that scenario, we did do Wolverine cutting balloons in both branch. So we did 2.5 in the diagonal and a 3.0 in the LED. I think on the off chance that there's a little flap that we're missing, you know, but on IBIS, but you know, we're pretty confident that things look good. And then this brings into the situation of what's your stenting technique at this point. And so,
do you have image of IBUS
we
before
did.
and after cutting balloon?
We do live. We did this case live, and it was done with the Avigo 3 system, and it was there as a loaner, and so it's archived on Boston Scientific System somewhere in the United States. So it's not archived on our system, unfortunately. So we spent quite a bit of time over the last week trying to track that down around the country for everybody, but unfortunately they could not find it. So, but you could see clearly, like you showed in your panels, the favorable scenario where both wires are in the same confluent zone. And so this is a technique for stenting that and you know, Stefan and Fred, I'm sure. And so Stefan's been a big proponent of this double kiss balloon. He was calling it T-stent, but it's more of a double kiss tap. And I'll walk through this real quickly because I don't know how much people are using it. It's a nice technique. We use it a lot at Emory now just because of his influence when we were fortunate enough to work with him. And so if you look, this is the kind of scenario where both wires are here. He likes to use basically a bumping balloon or a defining balloon in the main branch. And so you can see there's a stent out in the side branch. We'll get in a nice view that you can clearly see the bifurcation. So you know you're in a good position to understand what you're looking at. And so we'll pull the stent back to where we think it should be to just have the minimal amount of protrusion into the main branch, but still be covering the ostium of the side branch. And so we'll pull that back. We'll inflate the main branch balloon at that point to see if there's interaction with just one or two stent struts that are being kind of folded over or encroached upon by the balloon. We'll look at that at multiple angles to understand that. And that gives us the comfort that we've actually gotten the whole way from the side branch into the main branch. And it's kind of like a tap, but so we will then again kind of confirm that location. If you look here with the balloon still in place in panel F, we'll deploy the side branch stent, and then you pull the balloon back a little bit. So the side branch balloon comes back and the main branch balloon goes up, both go up, and you kiss, but you don't crush the stent by doing that. And so you basically have kissed the two, but you've left, as you see in M, an undistorted stent sitting in place. And so the idea is that we're going to concertina this stent back up with the new stent going in. And it's best to leave the uninflated balloon in the side branch in place like this, because the big fear that most people have if you're going to do something like this is that your new stent is going to get caught on the old stent edge that's hanging into position. And so with the balloon in place like this, it sort of as a bumper balloon. So when your new stents pass through in panel I, it doesn't catch on the edge. And so you can get it into position where now when we inflate it, you'll be able to push it up, and it does fold this last strut up into the carina. And you're left with the gap at the other side that everybody worries about. But then you pot, and when you pot,
do you think that at this point you produce a mini crash of the stent at the side branch?
I think it has to do with how much you've hung out. I think if you've done your tap nicely, I think you carina, or I think you concertina the stent back up. You almost accordion it back up rather than fold it over the lumen, so you don't actually have a real mini crush. I think if you have more stent than you desired, I think you invariably do create, exactly like you said, a mini crush scenario. The goal is to not have enough stent in here that you can mini crush it. The goal is to have it just barely protruding and then push that back up into the carina. And it's with the pot segment and the next kiss. So you'll pot, then we'll rewire the side branch, and then obviously we kiss. And when you kiss, it pushes this flap. And we have this on a pig lab experiment with angioscopy and then micro CT that shows that this corner then does get covered with stent and medication. And so you do the final kiss, and that's what pushes that down. And so you're left with this kind of elegant, sort of simple bifurcation strategy with two kisses and hopefully not a geographic miss if you've used this balloon adequately or appropriately to try to understand how far back to pull this stent. So this is this
two kissing and two pot.
Correct. Yes. Yeah. Correct. And so this is what we did. So we do the side branch first all the time, and this is how we're doing this. This is a side branch stent. It's a 2.5 long stent, a 3.0 stent in the LAD, And you can see we've pulled this back and we're kind of measuring to see exactly where do they interact and where can I understand exactly with the contact with the balloon. We look at this in multiple views. We do multiple times of bringing it back to just have just enough into the main vessel, but not protruding too much that you're going to create a mini crush. And then we deploy the side branch with a balloon in place still. And then that's when you're going to do your first kiss. But the first kiss is not done in a typical fashion where you do a two-step kiss where you're going to inflate the side branch, inflate the main branch, and then kiss. We pull the balloon back. You can see this balloon is now no longer just in the diagonals, back into the main vessel as well. And we kiss the LAD in the diagonal at the same time. So that stent architecture hasn't been folded. It's sitting there basically as a hollow sort of straw poking into the main branch. And then at that point, we come back and we stent the main branch, hoping to accordion the stent back up. And so we've stented downstream first. And then this is a long 48 millimeter stent going from the mid LAD across the diagonal side branch all the way to the left main. And then we pot the left main with a 5.5, and then come back and you see in the first panel on the side here, we wire back through into the side branch without a whole lot of difficulty. And we go back and we do a final kiss then with a 2.5 in the side branch and a 3.0 in the main branch. And then because we on IVUS had a little bit of stent hanging out into the left main and the guarantee, which I like, you can look at all the different ways. We can go LAO cranial and hope that you have it just perfectly hit on the left main, or you can go super LAO and all kinds of different techniques you can employ to try to get an osteal flush stenting job done. But the osteal flash really kind of takes a lot of that out of play. If you just hang a strut or two out and then flare it, you don't have a geographic miss. You haven't left stent behind that some other poor person's going to come by and have to try to figure out how to get through at some point. And so we osteal flash quite a bit when we're doing osteal lesions. And then obviously IVUS and have I think a beautiful final result. And so it's a lot of very complex things to overcome. It doesn't have the same complexity of the one issue that I was sort of pressing you a little bit about, is what do you do when you're left with when we aren't that fortunate and our retrograde wire maybe did come through subintimal and we do have a flap between our two branches, and how do you best treat that? But I think it's a nice case. It exemplifies a lot of the things in your very nice article that I think are really germane to this case. So I appreciate your comments, or if you have any things of commentary or
congratulations for the excellent result, because it's a very complex case with two bifurcations. It's a CTO with two bifurcations at the level of the left main and at the level of the LAD diagonal. So an excellent result and excellent technique. So
you didn't do anything in the osteal with CERC, right? You just crossed over. Is that right?
We didn't, and we did IVUS into it. It looked clean, and I don't know what your feeling is, Dr. Pan, whether you would open up the stent strut into the circumflex or whether you would just leave it as it is.
No, in my opinion, if angiographically the ostium of the CERC is okay, I don't perform kissing, only in case of compromise.
I feel the exact same way. I mean, I think it's a common thing that you watch people do where they feel compelled to open the struts, but I think if the
some people in the IVC systematically open the CERC, but it's not a consensus in the club. My opinion is like you. No, if you have an excellent result, don't touch the ostium.
I feel the exact same way, both from the fear of dissecting a good vessel after I kiss, or I don't like to distort the stent struts if I've got an optimal result. So
I agree.
Well, Tanvir, I think it's unfortunate Dimitri couldn't get on because I know he had a really, really super case to show. And I think there's a lot of good discussion. I welcome any comments you have, Tanvir.
I only miss the image of the IVUS, no? Because it's interesting to see the flap and the relationship and everything. So
I think Bill covered the gist of what was described in the European Bifurcation article in elegant detail, and I think showed a lot of the complexity that was talked about in Dr. Pan's presentation. It's a great case. I'm glad we had this time to go through the case very, step by step as to how you did it. And it's wonderful to have Dr. Pan discuss the paper and Bill back at Emory. And, I did help train him some years ago, but he's done a great job and really making this program here, the largest program and the best program in the country. So thank you for coming and helping our viewers who will understand this better. And as part of the SCAI Bifurcation Club, this has been great. All our sessions have been great. You may see very few participants. Actually, the chat lines on LinkedIn and Twitter and SCAI is open, and people can watch through that as well. And they're literally being fortunate to have thousands of people look at these cases even afterwards in the SCAI Bifurcation Club video series. But thank you very much for being up in Spain so late at night. I know it was beautiful and wonderful in Cordoba right now. Been there last year, and a wonderful place along with Seville and all that. But thank you again, Bill. Is there anything else you want to say? Anything you or Dr. Pan want to say to conclude that otherwise?
No, it's a privilege, and appreciate you inviting me. It was a pleasure to meet you, Dr. Pan.
Thank you.
Thank you very much. Thank you very much.
It's a pleasure.